make a difference every day. We are a company driven by new discoveries and possibilities. We've been helping people see better since 1945. We employ more than 20,000 associates in 74 countries, supplying medical professionals who treat patients in over 140 countries. We are Alcon. We are research and development associates worldwide who work to help the 20 million people who are blind from untreated cataracts, the 1.7 billion people who suffer from presbyopia, the 153 million people with uncorrected refractive errors, the 93 million with diabetic retinopathy, and the 67 million living with glaucoma. We are the global market leader within the growing $23 billion eye care industry. We operate 18 state-of-the-art manufacturing sites and distribute our products through 67 owned and third-party distribution centers around the world. We ensure a reliable supply of the highest quality eye care products to our doctors and their patients. We have partnered with eye care professionals to develop new and innovative ways to improve outcomes for cataract patients. We believe everyone should have access to quality eye care, regardless of geographic location or economic circumstances. Whether it's groundbreaking research and development, philanthropy, exceptional sales and service, making a difference in our community, or changing lives across the globe, we are there. We make a difference, helping the world look, see, and feel better. And after our first 70 years, we are just getting started. We are Alcon. We help make a difference every day. We are a company driven by new discoveries and possibilities. We've been helping people see better since 1945. We employ more than 20,000 associates in 74 countries, supplying medical professionals who treat patients in over 140 countries. We are Alcon. We are research and development associates worldwide who work to help the 20 million people who are blind from untreated cataracts, the 1.7 billion people who suffer from presbyopia, the 153 million people with uncorrected refractive errors, the 93 million with diabetic retinopathy, and the 67 million living with glaucoma. We are the global market leader within the growing $23 billion eye care industry. We operate 18 state-of-the-art manufacturing sites and distribute our products through 67 owned and third-party distribution centers around the world. We ensure a reliable supply of the highest quality eye care products to our doctors and their patients. We have partnered with eye care professionals to develop new and innovative ways to improve outcomes for cataract patients. We believe everyone should have access to quality eye care, regardless of geographic location or economic circumstances. Whether it's groundbreaking research and development, philanthropy, exceptional sales and service, making a difference in our community, or changing lives across the globe, we are there. We make a difference, helping the world look, see, and feel better. And after our first 70 years, we are just getting started. We are Alcon. We help make a difference every day. We are a company driven by new discoveries and possibilities. We've been helping people see better since 1945. We employ more than 20,000 associates in 74 countries, supplying medical professionals who treat patients in over 140 countries. We are Alcon. We are research and development associates worldwide who work to help the 20 million people who are blind from untreated cataracts, the 1.7 billion people who suffer from presbyopia, the 153 million people with uncorrected refractive errors, the 93 million with diabetic retinopathy, and the 67 million living with glaucoma. We are the global market leader within the growing $23 billion eye care industry. We operate 18 state-of-the-art manufacturing sites and distribute our products through 67 owned and third-party distribution centers around the world. We ensure a reliable supply of the highest quality eye care products to our doctors and their patients. We have partnered with eye care professionals to develop new and innovative ways to improve outcomes for cataract patients. We believe everyone should have access to quality eye care, regardless of geographic location or economic circumstances. Whether it's groundbreaking research and development, philanthropy, exceptional sales and service, making a difference in our community, or changing lives across the globe, we are there. We make a difference, helping the world look, see, and feel better. And after our first 70 years, we are just getting started. We are Alcon.
Good afternoon, everyone. So you're tuned in to TMC EyeTV. I'm Rob Papa, a Vitreoretinal specialist at the Medical City Eye and Vision Institute, and I will be one of your moderators for this exciting afternoon, together with my good friend and colleague, a cornea and external disease specialist, also at TMC EVI, Od Reyes.
Thanks, Rob. Good day, everyone, and welcome to our second episode of TMC ITV, Ophthalmic Instruction Without Borders. This is the official digital platform of the Eye and Vision Institute of the Medical City.
Let me start off by commending the entire organizing team comprised of the residency staff of the Medical City Ophthalmology Department and the team of Kevin Mayuga for such an incredible webinar during the first episode of TMC ITV. I heard a lot of compliments about the first episode regarding the graphics, the layout, the format, and the topic. And personally speaking, it was probably one of the better, if not best, webinars I've attended, both locally and
I agree,
internationally.
Rob. I know that during these times, there's just so many webinars being offered, but I believe that any avenue of learning will always be welcome, especially during this unusual circumstances. Now, ITV is just the Medical City's own way of ensuring that quality ophthalmic education is available to anyone, anywhere, no matter what the situation may be. And as an added benefit, CPD points will be awarded to you, our audience, for registering and for attending.
So Oj and I are happy you can be joining us here. We've prepared an excellent program for all of you. Before we start, we would like to request everyone to fill up the attendance and evaluation forms that we will be posting later on in the comment section below. This afternoon, we will be discussing how to manage posterior capsular tears and vitreous loss during cataract surgery, and shifting into a possible paradigm shift for all phaco surgeons.
Now, this topic is of particular interest to majority, or should I say all, modern cataract surgeons as it revisits
facing the challenges that confront us. The same mindset is an important characteristic that each and every cataract surgeon should have in his or her arsenal. As the famous poet Rabindranath Tagore puts it, you cannot cross the sea by merely standing and staring at the water. In the next few minutes, we hope to answer the hard questions that come to mind with regards to one of the most feared intraocular surgery complications for an ophthalmologist. Based on previous experience, cataract surgeons like Dr. Richard Ko and myself have sought to come up with a better technique in managing posterior capsular tears and the vitreous loss that comes with it. From this, a collaboration was made with the Retina Service, headed by Dr. Arnold Salud, to come up with a solution that can offer the best outcome for our patients. Ultimately, we have formally included the teaching of anterior vitrectomy to our residents, either through live surgery or through wet labs. And just as what we have done here in Medical City, we would like to hopefully see these techniques included into the training of all ophthalmology residents, which will serve as a useful tool to have in their arsenal when the going gets tough. As the head of the Medical City Eye and Vision Institute's Cataract section, I would like to express my gratitude to our speakers, Drs. Richard Ko, Arnold Salud, and Mahesh Mangali, and our hard-working residents for putting together this session with one of the most novel and practical topics for discussion. I hope you will find this episode of ITV useful in your continuous desire to improve your craft. Finally, as cataract surgery has grown by leaps and bounds in the past few decades, this progress would not have been possible without the help of our industry partners who have always worked hard to study and improve the science and technology that are of utmost importance in innovating this art. Alcon has been one of our integral partners in this growth, and we would like to acknowledge their support in our thrust of providing ophthalmic instruction without borders by being our partner for this second episode of ITV. Thank you, and I hope you enjoy this episode.
Thank you, Dr. Cheng. For today, we will be having three esteemed speakers who will take us on a systematic approach in learning this new technique. Dr. Richard Ko, Dr. Arnold Salud, Mr. Mahesh Mangali. And if you have any questions at all during the duration of this episode, please again feel free to type them down in the comments section, and we will have our speakers address them at the end of all the lectures.
So our first speaker today is Dr. Richard Ko, or Rich, as he is known to many. He finished his residency at the University of the Philippines, Philippine General Hospital, where he was likewise the chief resident. He then underwent neuro-ophthalmology training at the Jules Stein Eye Institute, UCLA. Now, Dr. Ko is a founding member and a co-secretary and scientific program director of the Philippine Society of Cataract and Refractive Surgery. And currently, Rich is affiliated with the following institutions: UPPGH, Associated Eye Specialists, American Eye Center, Manila Doctors Hospital, and of course, the Medical City. We are very pleased to give the floor to Dr. Rich Ko.
Thank you, Oj and Roby. So good afternoon, everyone. Thank you for tuning in. So let's get right to it. So I'll talk about management of PC tears and vitreous loss during cataract surgery. I'll give you some practical tips and perspectives from the anterior segment surgeon, to be followed by perspectives from the posterior segment surgeon. Now, notice that the main title is in the form of a question mark. No? And hopefully after the two talks, you'll understand what we're trying to propose here. And we should be able to answer this question together in the affirmative. I want to start by saying that I am not a retina specialist. I do not want to start a quarrel with the Vitreoretinal Society of the Philippines. I will say that I am a cataract surgeon with humble skills in anterior vitrectomy. These are skills that I learned together with my partner in retina for 20 years, Dr. Salud. And I'd like to acknowledge him and Dr. Cheng, my partners in crime, for helping me put together these slides. So, let me just qualify first. What we're talking about here are small, medium-sized PC lens without any drop lens material into the vitreous. Let's be clear about that. I think that anything more than this, you should just close and refer to the VR surgeon, because you'll probably do more harm than good in those cases. So we'll talk about cases that I think are manageable by the anterior segment surgeon before you call on your retina partner for help. It's always nice to start the talk with a little introspection of things and perspectives. Let me ask everyone in the audience, have you thought about this? What is your current rate of PC rupture and vitreous loss? The last 50 cases you did, the last 100 cases you did, have you thought about this recently? While you're thinking about that, have you thought about what it should be in terms of what is the national standards, worldwide standards, or at least what is in the literature? So think about that for a while. Let's take a look at standards 100 years ago. It's always nice to look back. No? So this was the standard incision. There was no controversy about the incision 100 years ago. The controversy at this time, at the start of the century, was really between ICC and ECCE. And at this time, they were already trending towards ECCE. Just as a sidebar, I'm glad this is one complication we don't see anymore nowadays. I can't even imagine what that looks like. Now, the upper eyelid protruding into the anterior chamber through the corneal slot. I'm glad we don't see that anymore. So anyway, O'Connor presented a 3% vitreous loss rate in a small series with 97% of his patients seeing 20/30 or better. This was a report in AJO in 1920. It was a small series in what was then classic ECCE. Let's look at the bigger series. Dr. Barak presented a 1,000 patient series, a vitreous loss rate of less than 1%. This is 1920. That's really fantastic, no? Such was the state-of-the-art sutureless surgery in the 1920s. A true incidence at that time was probably higher, no? Probably as high as 30% in some surgeons. And with vitreous loss, the standard at that time was to just do SI, sweep as much vitreous as they can, and then hope for the best. No? But, this slide tells us that even 100 years ago, back then, there were some individual surgeons who, through the refinement of their techniques in cataract surgery and having done thousands of cases, are able to come up with very, very good results consistently. It was true 100 years ago, and I think it's still very true today. So let's jump to today. The rate of PCR in the literature was as high as 15% up until 2000. At that time, we were all trying to learn how to do Phaco. And once we all learned how to do Phaco, starting 2000, the incidence of PCR has gone down. And it's actually even smaller, as low as 3.6% for very experienced surgeons. I think a good guideline would be this. No? In practice, you should be doing. You should have a PCR of 2%, meaning in for every 50 cases you do, you rupture one. It would be nice to make it 1%, meaning you rupture the PC in 1 out of 100 cases. No? But I think everybody's long-term individual goal should be this, 1 in 1,000. No? After all, we tell patients today that modern-day cataract surgery is 99.9% successful. So that really translates to this, less than 0.1%. And I'll tell you now that there are individual practices today that reach this number or come very close to it. No? These are not impossible numbers to achieve. It's nice if we could make that as our long-term individual goal. So we all agree we need to do proper vitrectomy. This is the big difference between having a quiet eye and a good day one post-operative result versus having to follow up these patients for the next several weeks or months with all of these chronic problems. No? So we all agree we need to do a proper vitrectomy. I think there's no controversy with that. Unfortunately, this skill is not required to graduate in most residency programs. We're not taught to do this. So what happens usually is people learn on the job. Now, when disaster is already upon them, is when you learn how to do it properly. So this is something we've discussed with my partners. The last few years, we said, now, if it's going to happen anyway, if it's bound to happen to everybody anyway, why not just teach this formally? Why not? And extending it further, why don't we teach it to all anterior segment surgeons? Now, after all, if you're a Phaco surgeon, wouldn't you want to have this skill as part of your OR arsenal just in case something like this happens and you don't have a retina to help you with this? At least you can handle the case by yourself. So this is really the whole premise of this week's episode of the EyeTV, is for us to teach the proper way to do vitrectomy. Some of you may recognize this slide from the basic course. It's a one-slide summary of what I think should be the mental flow chart of the surgeon. What should he be thinking when he ruptures the PC? It's a very busy slide. Don't worry. I've broken it down into 3 easy sections, and then later on we'll go back to the slide again to put everything together. So that very, very busy slide can be broken down into 3 sections. And for the residents and faculty of the medical city, for easy recall, we've used the acronym of the Eye Vision Institute now. So EVI. So E stands for early recognition, your immediate actions, what you need to do when you notice a rupture in the PC, vitreous management, which is the main bulk of the topic, and then IOL decision making. And then later we'll put together everything into that one summary slide again. So what you do here will be very important because this will determine if your PC rent will increase or not. So you have to recognize it early. You can't solve a problem if you don't recognize it. So there are many signs of early PC rupture. For example, sudden pupillary constriction or dilation, a sudden deepening or flattening of the AC. Phaco was okay, and then later on you lose phaco efficiency. There's now the fragments don't follow as much into the port. There's difficulty in rotation of the nucleus suddenly, some sudden increase in the ROR, or sometimes radial folds in the PC. Just to mention that the classic pupil snap sign is different. No? That's actually a sign that you see if you rupture the PC during hydro procedure. It's a very rare condition. So that's totally different from what we're talking about here. Sudden pupillary constriction or dilation during surgery, which is to be differentiated from that pupil snap sign when you rupture the PC during hydro procedure. So again, your immediate actions here will determine if the size of the rent will increase or not. So first, stay calm and keep cool. What you should never do is this. Do not immediately pull out of the eye because you'll probably just increase the size of the rent if you do that. That's the first instinct of the surgeon. You rupture the PC. Immediate instinct is to pull out. Do not do that. So foot position back to 0 or 1, depending on the depth of the AC. And then you really want to lower the bottle height and other parameters. And then before you go out, you inject viscoelastic by the side port, and then you go out slowly. Okay? So instead of pulling out immediately, this is what you should do. You're doing this again, really. The PC rent size increases if there's a pressure differential between the AC and the PC. No? So when you immediately pull out, the low pressure, the vitreous from the high pressure will go into the AC. And that's why the PC rent enlarges. Now, similarly, if you're outside the eyeball and you know that there's a PCR, be careful about suddenly introducing irrigating fluid into the AC because the reverse will happen. No? Again, it's the pressure differential that increases the size of the PC rent. So as part of the easy recall for the acronym E, actually what you're doing here is you're equalizing the AC and the PC pressure so as to decrease and to control the size of that rent. Okay? So the main bulk is vitreous management. Now, this will depend on a few things. No? You have to take a moment to assess the situation. What do you have, and what are your options? Do you have a retina friend on standby? Do you have OR needs for retina, for vitrectomy? These are things you have to take into account. No? And it will all depend on a few things. No? First, check if there's vitreous or not. Sometimes you rupture the PC, vitreous need not come out, no? Especially for young patients. In those cases, if there's no vitreous, you might want to consider performing a posterior continuous curvilinear capsulorhexis, and you can still put the IOL in the bag. If you're not sure, use triamcinolone. We'll go back to triamcinolone in a while and its uses for anterior vitrectomy. And then what is left? You have to assess at which point of the phaco surgery did you rupture the PC. Did you rupture it at the start when you still have a very large nucleus there? You might want to think about converting. Or did you rupture the PC towards the end, where you only have epinucleus and cortex, and you'll probably be able to continue with the phaco? So think about, again, can they still be removed by the phaco? Is it time to convert? Can you remove them manually? Sometimes, if you have a PC rent, you're worried about that lens dropping into the vitreous, you might have to put viscoelastic and then anteriorize the fragment into the AC. Your goal here is really to prevent further lens drop, no? So you might have to think about using a lens glide, a spatula, constricting the pupil after you anteriorize the fragments, and then start calling for help from the retina specialist. No? So it really depends. It's a dynamic situation that depends on a lot of things. So you've decided now you want to do vitrectomy, no? That's a given. You've decided you want to do vitrectomy. Now, in the older machines, there was this setting about IA cut and cut IA, and I noticed many surgeons still don't know the difference between the two. So if you have a lot of vitreous at the start, you want to start with the vitreous cutter on. Then when you've cleaned up a lot of the vitreous and you're finishing the surgery, then you can end with IA cut. And similarly, in newer machines now, you can actually just do cutter on and off. No? But in older machines, you will see these settings, IA cut and cut IA. As I mentioned earlier, triamcinolone is a secret weapon of anterior segment surgeons. I wish more phaco surgeons would have this in their OR. I'd say it's free, but it's not free, of course, but it's practically free. It's right there. So I wonder why not many phaco surgeons are using this when they do rupture the PC. So there are two approaches. The anterior approach, the corneal approach, which is what we've been used to, what we know. And so if you're doing this, my suggestion is never to use the main phaco port. You have to create a new side port. And I will show you a nice video later to make you understand why you should never do vitrectomy using the main port. I think that this latter route is the better option. No? I think if it's done properly and by a qualified surgeon, this is the procedure that will allow you probably to continue with your phaco as if nothing happened, and to be able to implant the original IOL that you discussed with your patient, especially if it's a premium IOL or a toric IOL. So to me, the pars plana approach, I think, is the better route. Doing anterior vitrectomy using the label, this is something I learned from Dr. Salud. You have to put your vitrector down there below the PCs, because most of us are doing just this. No? And again, you're just attracting the vitreous into the AC, and you probably increase the size of the PC rent. So again, should be down here. He always tells me, just go down there deeper, deeper, just below the PC. And again, not up here. Okay. So as a non-retina specialist, I have to admit, sometimes I can't see the vitreous. No? The retina specialist showing me this is vitreous, but I really can't see it without triamcinolone. No? And again, if you do anterior vitrectomy before triamcinolone, there was really no endpoint. You didn't know if you were done or not. You just hope for the best. No? And as I mentioned, we need to clearly visualize the vitreous and clean it up to avoid all of these complications. And really, triamcinolone does this job so well. No? Because now I have an endpoint. When I do vitrectomy, I can see an endpoint. Again, just to mention over and over again, do not use the main phaco port for your anterior vitrectomy. And ideally, pars plana approach is better than anterior vitrectomy. So let's look at some videos. This is, I think, 12 years ago before we triamcinolone. So before triamcinolone, this is what we do. Here I am polishing a PC, and then suddenly I rupture. There's a little rent. So again, do not immediately pull out of the eye. Relax. Inject viscoelastic by the side port. And then slowly pull out of the eye. And then reassess the situation. So again, you're equalizing the pressure in the AC or the PC. So make sure that the AC is fully formed before you go out. Okay. Then reassess the situation. In this particular case, it was a young patient. Unfortunately, we didn't have triamcinolone 12 years ago. But I thought there was no vitreous here, so I just did a posterior curvilinear capsulorhexis. And in doing so, if vitreous doesn't come out, you should still be able to put the lens in the bag as originally planned. Okay. So this was before we had triamcinolone. Okay. In a similar case, no, in the triamcinolone area, pretty much the same case. Now here I am towards the end of the surgery. I'm polishing it, and then I rupture it. I notice the rupture. Before going out, inject viscoelastic by the side port, reassess the situation. So again, I attempt a posterior capsulorhexis, but for one reason or another was a failed. It was not as continuous, so I didn't know if there was vitreous or not. So let's inject triamcinolone. Turned out there wasn't really much vitreous in the AC, but I think that in this case, the triamcinolone gave the surgeon the added confidence that there really was no need to do any cleanup with the vitreous here. Was able to put the IOL in the sulcus. And then if you do this, it's nice to do an optic capture. No, you see that very nice fish eye of the anterior capsule. You have a very, very stable lens in the sulcus. So again, in this case, the triamcinolone gave the surgeon some extra confidence that this was a clean case that did not need further vitrectomy. This is a very nice case from my colleague, Dr. Badge Bolina. Hi, Badge. Are you in the audience? It's a very difficult case, an NO 5 to 6. She was able to do very good phaco. Remember this? Early recognition. See if you can recognize what happens here. There. That last item. What seemed to be like radial folds. Okay. Injecting further viscoelastic. You see those folds there? The surgeon wasn't sure if that was a rent or not. So again, she was able to finish the phaco, but then that radial fold in the PC is very suspicious. No? And here she has that little chunk of nucleus there that seems to be floating, so she was not sure if the PC was intact or not. So why don't we try to visualize it using triamcinolone? So she did the right thing, visualized it. It turned out the PC was intact. And again, this is one of those instances wherein the triamcinolone really gave the surgeon extra confidence. No? So he did not have to do a vitrectomy in this case because the PC was intact. Again, it's nice to have this triamcinolone on hand. No? Just gives you that extra confidence whenever you don't see the vitreous or you're not sure. Okay, so this is what you should never ever do. Okay, do not ever do this. This is a surgeon who's unidentified. He did phaco on an NO5. Phaco turned out well, but at the last chunk, I think he ruptured the PC. So up until this point, he was still doing the right thing. He did not pull out. He injected viscoelastic on the side port and started to pull out. He still did the right thing, injecting triamcinolone here. But as you can see, all that vitreous coming out of the main wound. So this was the error, is that he did the vitrectomy the whole time using the main port. So this had no ending. His first vitrectomy here, I think, lasted for about 10 minutes. Okay, look at all that vitreous coming out of the wound. That vitreous that's stained by triamcinolone. No? That's all just coming out of the wound, and there's going to be no ending to this surgery. Okay, so still a lot of vitreous in the wound, but he decided to stop the vitrectomy. I don't know why. So again, notice there's still a lot of vitreous in the wound. So take a guess what's going to happen with IOL insertion. So look at all that vitreous. He was planning to put in a 3-piece, enlarge the wound, but because of that vitreous incarcerating in the wound, he had a difficult time inserting it. First attempt, nope. Second attempt, nope. Third attempt, again, because of all that vitreous incarcerated in the wound, no, it's not really surprising he was having a hard time. And finally, I think he was able to put this in. But of course, the IOL is not stable because there's a lot of vitreous in the AC. Okay? Again, no surprise, no? All the difficulties here, no, not surprising because of the choices that the surgeon made. So he ended up cutting the IOL, and he should have just quit at this point. But what did he do? He did vitrectomy again using the main port, and this went on for another 20 minutes. Another 20 minutes of this. I'm just gonna fast forward the video in the interest of time. But this went on for a long time. So this is what I was saying, no? There's no endpoint in your vitrectomy. Okay? And again, look at all that vitreous coming out of the main wound. So again, please, if you're going to do anterior vitrectomy, the limbal approach, please do not use the main port for your vitrectomy. Okay, so this patient ended up a phakic, a very bad case. Okay. So there's just one quick slide on IOL decision making. It really depends on your remaining capsular support, if you have it or not. If you do have remaining capsular support, you can still put it in the bag. You might want to attempt a posterior capsulorhexis. For beginners, I actually have a preference for smaller rexes because this will almost always ensure that you have an IOL in the sulcus, whatever happens. If you don't have it, these are your options. This is probably the topic of another EyeTV episode. No, we won't have time for all of this. But, sometimes it's better to postpone. There's nothing wrong with telling a patient, I was able to do the first part of the surgery, which is to remove the lens, but I wasn't able to do the second part of the surgery. We might have to have a secondary surgery later on to put in a lens. There's nothing wrong with that. No, do not force yourself that you need to put in an IOL. That's always the mentality of the surgeon. I have to put in an IOL, this patient, no matter what. But sometimes it might turn out worse if you do so. Okay, so just let's look at a few more quick videos. Extend 5 minutes. It's a 85-year-old MD who had an NO5 surgery, cataract. Surgery was pretty uneventful, but towards the end here, look, there's vitreous in that subincisional sector. No? This is not from a PC red. This is probably from some zonulisis. So before time sinolone, what would we do? You'd probably just sweep this, cut it with vanish, just sweep it, and then that's over. And then you always be worried about traction, maculopathy, traction retina detachment. So do the properly, trace side ports. Do not use the main port, use the side port, and then do your vitrectomy and do this very well and do a good cleanup. So again, the triamcinolone really made it very easy for me to do this vitrectomy, when before I probably wouldn't stop 5 minutes, keep doing the vitrectomy until I think I'm done. But here, it gives you an endpoint in doing the vitrectomy. Okay. So the last video I show you, it's a 95-year-old female with a NO6 brunescent fibrotic cataract. There was some zonulisis preoperatively, but not so much. So did the usual phaco in this patient, very difficult, very dense. Did my usual chopping. So you can see it's a very, very dense nucleus. I had to re-inject viscoelastic several times midway. Finally, at the end, notice what's going to happen at the last chunk. That boom, last chunk. There, boom. I did rupture the PC. So again, first instinct, do not go out. Put viscoelastic in the side port, slowly go out, inject triamcinolone, and do your proper vitrectomy. So here, I can hear Dr. Shalud whispering to me, deeper, deeper, go down deeper, below that PC level. Okay, very nice cleanup. Put in a 3-piece in the sulcus, do an optic capture, and this can still turn out very well. Okay, so just wrapping up. So this is just that one slide, that busy slide I told you earlier. Let's go back to it. So again, 3 sections: EVI, early recognition, vitreous management, and IOL decision making. Early recognition also equates to equalizing the pressure. When you do rupture the PC, stay calm and keep cool. Do not pull out to the eye immediately. Lower the bottle height and other parameters. Inject viscoelastic by the side port. Pull out the eye slowly and then reassess your situation. What are your options? Depends again, the remaining epinucleus, nucleus, or cortex. It will depend if you have vitreous or not. Can they still be removed by phaco? Manually, is it time to convert? Your goal here again is to prevent further lens drop. So you might want to think about anteriorizing that chunk while you call your retina pal. Use a lens slide, a spatula, constrict the pupil. Then IOL decision making, again, depending on the capsular support. If there's none, you might have to do a secondary IOL, postpone later if you can. If you do it in the sulcus, do an optic capture, and sometimes try to attempt a posterior CCC because you might still be able to put the lens in the bag. For vitrectomy, again, anything more than what we described in this talk, just close and refer to your retina pile. Know the different settings in your machines. Do not forget your secret weapon for vitrectomy, triamcinolone. And again, if you're doing anterior vitrectomy, do not use the main phaco port. You have to create a new side port and consider a pars plana vitrectomy, because if done properly and by the qualified surgeon, this route is actually the best. No? It allows you to continue your phaco and put in the IOL that you plan to put in this patient. So after 23 years of doing phaco, this is what I believe now. I believe that this should be a skill set of the cataract surgeon. I don't know how to do it. I'm trying to learn how to do it, but I really believe that this is the way to go. Again, we're talking about mild PCNet, not for anything that's dropped. So these are the advantages. It's more physiologic because you pull the vitreous from under and not above and into the AC. I'll show you some diagrams later on this. It eliminates the pressure gradient between the AC and the PC. You have a better control of the tear size. And then if done properly, you can proceed with your phaco as if nothing happened. The best likelihood of implanting the lens of that you planned with the patient. Disadvantages, of course, we're not trained to do this. We might have to shift to peribulbar, retrobulbar intraoperatively if we have to do pars plana vitrectomy. And this is what I really fear, the possible retina complications if not done properly. I'd like to thank the residents of Medical City for creating these fantastic, and I asked them to make diagrams. They actually made animations to help us visualize this. So you have a ruptured PC, vitreous comes out. See, if you do anterior vitrectomy, this is what happens. You're basically just getting the vitreous into the AC, and in effect, you probably are enlarging that PC rent as you're taking the vitreous out in the AC. Remember again, if you're going to do this, you have to put the vitrector tip below the PC and not like this. But if you do the posterior approach, this is what basically happens. You have a PC red, vitreous comes out. If you take the vitreous from underneath, then actually it's possible to control the size of the PC red. In some cases, the flap of the PC might actually come down, make your PC red a little smaller than usual. So this is why I think the pars plana approach is really the way to go. My daughter helped me make some visual aids using household items, using this ball of string to represent vitreous, trying to create a posterior capsule with a rent, and vitreous comes out. See, if you do anterior vitrectomy, this is basically what you're doing. You're trying to pull vitreous from above, and you're probably just enlarging that rent. Versus, if you do this from below, then in theory, I think this is how I visualize this in my head. That's why, to me, the pars plana approach is more physiologic and probably better. So, the reason why not is that there were so many stumbling blocks why phaco surgeons are not able to do pars plana before. But I think those stumbling blocks are all gone now. No? Used to be there was no small gauge. That's not true anymore. We have small gauges for anterior vitrectomy. Used to be there was a low cut rate, but now we have very high cut rates even with anterior vitrectomy with the newer machines. We can go transconjunctival now. There's no need for that dissection. We have triamcinolone to aid us in doing vitrectomy. This last one is probably still true. No, your surgeons are always worried about opening a new vitrectomy pack and thinking about how they will charge this to the patient. So, but I think even for this last segment, we might also have an answer for this. The next speakers will discuss this more. So, I'm going to give way for the next speaker. Just a take-home message again: when in doubt about PC rent and vitreous loss, use triamcinolone. It's free. It's there. Why not use it? If you're doing anterior vitrectomy, do not use the main phaco port. Create new side port. Go deep, just below the PC level. Pars plana anterior vitrectomy, if available and doable, I think is the better route. I think reducing one's rate of PCR should be everybody's lifetime goal. If they can have a PCR rate of 1% 100 years ago, there's really no reason why we can't achieve this today. So in those rare instances that you do rupture the PC, let's please do the vitrectomy properly. So with that, thank you. I give way to the next speaker.
Thank you so much, Rich, for the informative and very interesting talk. And thank you for sharing your fantastic videos with us. I'd like to remind everyone to type in the comment sections any questions you may have. Now, before we move on to our next speaker, let's hear a few words from one of our important industry partners and our sponsor for this episode, Alcon.
The Centurion Vision System with Active Sentry Handpiece offers a new standard of Phaco safety to your cataract patients. The Active Sentry Handpiece is the first of its kind to include an irrigation pressure sensor, traditionally placed in the console. The sensor's advantageous placement enables it to detect pressure changes in real time. Working with the Centurion Vision System's Fluidics Management System, it initiates adjustments to maintain anterior chamber stability. By communicating with the system, the handpiece actively mitigates occlusion break surge for greater safety and stability in every moment of Phaco. The sensor also dynamically maintains target IOP, automatically compensating for incision leakage and adjusting patient eye level to further enhance consistency from case to case. With the introduction of the Active Sentry Handpiece, the Centurion Vision System advances Phaco safety and performance to the next level.
You could look at cataract surgery as simply a procedure that almost everyone will eventually need. But when you take a closer look, you'll find a once-in-a-lifetime opportunity to brighten your future by enhancing your vision.
As a result of this surgery, which has made my life so wonderful as far as my vision goes, I would have to say I am a pan-optimist.
Pan-optimists see life differently, because with the PanOptix trifocal lens, you can get more out of your cataract surgery. Cataracts form in the natural lens of your eye and block light from passing through, which prevents you from seeing clearly. During cataract surgery, a surgeon removes your clouded lens through a tiny incision and replaces it with a new clear lens. This is one of the safest, most common, and most effective procedures performed today, and technology like the PanOptix lens makes it possible to enhance your vision beyond basic cataract removal. If you have cataracts, everything you see is likely hazy and dull. After cataract surgery, things will look clearer and brighter. However, your basic cataract replacement option, the monofocal lens, only clears your vision at a distance. You'll likely still need glasses to see up close. The PanOptix lens lets you see far away, at arm's length, and up close with clarity, so you can see all the vibrant details of your life. With the PanOptix lens, you can enhance your vision for clear, complete focus, discover bright, vivid colors, see effortlessly without blurry zones, and reduce your need to wear glasses.
There is nothing that I can't do with my vision. It's been wonderful. My name is Sandy, and I am a pan-optimist.
Look on the bright side of cataract surgery. Seize life without cataracts. Ask your eye care professional about the PanOptix lens today.
We would like to thank again Alcon for sponsoring this episode, and as always, for showcasing their extensive arsenal of ophthalmic devices, which has helped many eye doctors improve clinical outcomes from then until the present time.
So moving on, the first lecture presented to us was from the anterior segment perspective by our cataract specialist, Dr. Ko. I believe that as a vitreoretinal surgeon, this can be best supplemented by a vitreoretina point of view, since we are, after all, dealing with the vitreous.
And for this next lecture, we have exactly that person that Rob is describing. So our next speaker will elaborate further on pars plana anterior vitrectomy technique, along with its rationale, indications, and even apprehensions that ophthalmologists might encounter when doing it for the first time. It is my pleasure to introduce Dr. Arnold Salud.
So Dr. Salud finished his residency in the University of the Philippines, Philippine General Hospital, and consequently his fellowship in vitreoretinal surgery in UPPGH, as well as in Nagoya National Hospital in Japan. He is a founding member of the Vitreoretina Society of the Philippines, and currently he is affiliated with the Medical City and the American Eye Center.
Now, to make this lecture more engaging and interactive, We will be having poll questions at the end of the presentation. So please make sure your mobile phones are ready because we will be flashing the QR code once the lecture ends. But for now, let us all welcome Dr. Arnold Salute to present to us pars plana anterior vitrectomy from the perspective of a VR surgeon.
Thank you, Oj. Rob, thank you. Rich. Well, thank you for the invite and for the opportunity to be part of the TMC EyeTV episode 2. The topic we have for tonight is something that is frequently lectured about. It's nothing new. In fact, I just attended one over a webinar among ophthalmologists in Singapore and Thailand about a week ago. Most experienced phaco surgeons believe vitreous loss is very much manageable with the usual limbal anterior vitrectomy. Vitreoretinal surgeons would all agree that the way to remove vitreous from the anterior chamber is through the pars plana approach. But most would likewise historically agree that a phaco surgeon should never use that route. That pars plana is our territory. Tonight, it's different. Dr. Ko, a renowned phaco guru, phaco surgeon at his best, and I, with all my 24 years of pure vitreoretinal surgical experience, both agree that the pars plana is the better approach, and that anterior segment surgeons should learn its principles and applications. Next slide, please. Before we started doing anterior vitrectomy, before we even understood how important managing vitreous loss was, 44% of those who develop vitreous loss would have a visual acuity of 20/70 or worse. 6% will be totally blind in a year, and 18% will have no useful vision. The two dreaded intraoperative complications are dropped cataract and IOL. The other potential complications would be your retinal tears and worse, your retinal detachment. The others mentioned are post-surgical complications. Next slide, please. Talking about how often one gets vitreous loss is almost like a taboo. No one likes talking about it. In fact, even papers on incident rates of vitreous loss are quite few. Vitreous loss can range from 1 to 3%, underreported, I think. My interest is actually on retinal detachment as a complication of vitreous loss management. An uncomplicated phacosurgery gives a 0.4% risk of retinal detachment. And this balloons to over 10% if anterior vitrectomy was done for vitreous loss. Next slide. Yeah.
Oh,
It's not moving.
sorry about that, everyone. So just a little bit of technical difficulties. Sige.
We're just fixing some technical.
Yes, maybe ask while we're waiting for the slides to be fixed. Maybe we can throw a few questions to Dr. Rich. Rich? We are okay. Sige. Okay, we'll delay the questions till after the lecture again. Okay.
Yeah, but I can't see my slides. Yeah. Okay. All right. Okay, I'm seeing it now. 4. I've always been curious about the post-operative visual acuity of eyes that had vitreous loss. Not a lot of literature can be found on this as well. The largest one I came across with was a retrospective study covering an 18-month period from 1988 to 1999 in UK. 3.6% of 2,558 eyes needed anterior vitrectomy, at par with the other papers that I have reviewed. Acceptable post-operative vision was defined as 20/40 or better. 86% achieved acceptable vision. Results were regarded as good despite having only 75% seeing 20/30 or better, and only 30% achieving 20/20 best corrected visual acuity. Next slide. Well, times have changed. Those numbers will not be acceptable anymore today. Having a final visual outcome of 20/40, when one used to do surgeries mostly on cataracts with preoperative VA of 2200, 2400, will always be dramatic. But today, when the phaco surgeons routinely operate on 20/20 cloudy, light-sensitive preoperative vision, a visual outcome of less than sharp 20/20 almost always is unacceptable. Cataract surgery has evolved to become a refractive procedure today more than ever. And the need to be able to perform a proper anterior vitrectomy has never been this important. Being surrounded by top phaco surgeons in the country in the last almost a quarter of a decade from 1996, I've come to realize there were two kinds of cataract surgeons. 24 long years of partnership with refractive surgeons. My partners would lose sleep over a 0.25 to 0.50 off-target post-cataract surgery refraction. If you want to be the refractive kind of phaco surgeon and be a cut above the rest, you need to understand, get convinced, and eventually apply whatever it is we will learn today. Vitreous loss is going to be just a detour. With proper anterior vitrectomy, you can still achieve the same results. Next slide. What then are the objectives of anterior vitrectomy? The general objective, obviously, is to manage the vitreous prolapse so you can safely proceed with the phacoemulsification and implant the lens that you really plan to use. To achieve the main objective, these are the specific objectives that one has to meticulously attain. You want to remove the least amount of vitreous possible. You have to remove all the vitreous in the anterior chamber. That's taking out the corneal wound most especially. Obviously, you want to preserve the remaining posterior capsule, and you don't want too much physical interaction with the iris, as will be described later on. Next slide. Two reasons why you don't want to end up removing too much vitreous. One, the more vitreous you remove, the more overall traction you generate on the peripheral retina. You don't want this so as to avoid acute intraoperative retinal traction that consequently may lead to retinal tears or even detachment. Second, the more vitreous you remove, the more hypotonic the globe becomes. And that would make it even more difficult to implant the lens. Not to mention increase the chance for the posterior capsule tear to further enlarge. And this is where most attempts to implant the lens end up falling into the vitreous, as pictured on the right. Next slide. Whether you end up putting the IOL in the sulcus, implanting an artisan lens, or even anterior chamber IOL, please always remove all the vitreous in the anterior chamber prior to the implantation. Otherwise, you will end up with everything that's written there. Distorted pupil, corneal problems, chronic persistent inflammation, and perennially red eye, glaucoma, late retinal detachment, or even endophthalmitis. Next slide, please. Now, because your ultimate goal, if it's still possible, is to deliver on what you discussed with your patient for over an hour of their time about the benefits of a premium lens, such as a panoptics, you have to seriously preserve the remainder of that posterior capsule. And a complete removal of vitreous that has gone onto the anterior chamber without further enlarging the PC tear is always a challenge. Next slide. You don't want cystoid macular edema to haunt you despite all your efforts. Prolonged surgery causes inflammation. If you don't want to add more inflammation, do not traumatize the iris. Vitrectomy per se does not cause macular edema unless there is vitreomacular anatomic traction. CME is mostly due to mechanical trauma of the uvea. Next slide, please. Everything that was just enumerated with regard to the specific objectives of anterior vitrectomy is listed down there. A study that's actually published years ago lays down the advantages of pars plana anterior vitrectomy over limbal anterior vitrectomy. With pars plana approach, it was documented the surgical time was actually shorter, greatly because less vitreous had to be removed. Removal of vitreous from the anterior chamber was demonstrated to be much more efficient. Structural integrity of the posterior capsule was better preserved, and there was hardly any contact with the iris. The diagram to your left actually shows it all. It allows the strategic position of the vitrectomy probe with the port facing the pupil in the anterior chamber. The pressure gradient generated by the infusion's positive pressure anteriorly and the vitrectomy probe's negative pressure posteriorly facilitates the efficient removal of vitreous in the anterior chamber. Next slide. Now, despite all the supposedly known advantages of the pars plana approach, many remain skeptical, perhaps, of the perceived misconceptions about its potential dangers, its economic impact of the cost of surgery, as well as its questionable doability or even abuse by an anterior segment surgeon. Next slide. Does it really carry a higher potential for retinal damage? Well, the old vitrectomy system most of us grew up with was with the large 20-gauge instruments. Large sclerotomies, in and out with rather large instruments, vitreous getting incarcerated in the sclerotomy site, vitrectomy cutters with at most at that time 400 cuts per minute. Definitely a lot of potential for unwanted retina traction. But today is different. Small gauges, trocar cannula system, minimal or no traction at all going in and out of the eye. Cut rate now for anterior vitrectomy can be as high as 5,000 cuts per minute. With all this new technology, does pars plana approach really carry a higher risk for retina traction? In vitreoretinal surgery, the two areas we potentially can damage are posteriorly, the macular area, and anteriorly, the peripheral retina. The posterior pole may be damaged by a direct hit with our instruments, be it the vitrectomy probe or some retina forceps, while the peripheral retina mostly via undue vitreoretinal traction. The tensile strength of the peripheral retina is 1/100 of that around the optic nerve, while the vitreous, known to be more adherent to certain parts of the retina, is most adherent and almost inseparable from the retina in the vitreous base. The weakest part of the retina, that is the periphery, plus the most adherent part of the vitreous, that is the vitreous base, plus excessive vitreoretinal traction from poor vitrectomy technique are the basic ingredients for retinal tear production. Now, just look at the configuration of your collagen fibers, pictured on your left. Okay. How they converge towards the vitreous base. Look at how retinal tears are potentially formed when the vitreous is pulled anteriorly. Anterior vitrectomy is a simple procedure if the principles of vitrectomy are followed. The least vitreoretinal traction feasible is when the port of the vitrectomy is perpendicular towards the pupil and the anterior chamber, from just below the plane of the posterior capsule tear, which is what I always tell Rich. And pars plana approach allows that best. Next slide, please. So how safe and effective really is pars plana anterior vitrectomy, especially when performed by a non-retina ophthalmologist? And I was able to find a retrospective study, again, spanning over 8 years from 2010 to 2018. 348 eyes underwent pars plana anterior vitrectomy by the same surgeon, and 2.3%, 8 out of 348, representing the cases of posterior capsule rupture with vitreous loss during phacoemulsification, had unplanned vitrectomy. The rate of retinal detachment for this study was only 0.9%, way below what I cited in my earlier slides. And none of those cases of vitreous loss actually developed retinal detachment. The lower incident rate is mostly attributable to the reduced vitreoretinal traction and the trocar-based surgical technique. Next slide. So I'm just showing this video. You can play it. Okay. You know, I even had to make a paracentesis on one side because, you know, after starting my vitrectomy, I realized there was still vitreous going on to the wound of the phaco. And if you look at the view where my vitrectomy probe is coming out, that's at the 11 o'clock. And you will see that the actual tear there, I don't know if you can see it, at the 11 o'clock is the horseshoe tear, exactly where the surgeon pulled on to the vitreous. Okay. Exactly what I showed in the diagram a while back. Next slide, please. Now, I'm showing you, well, that's the nucleus going down, but that's not what I want to discuss with this slide, with this video. What I'm showing you is that after removing the drop nucleus, I always take out all the vitreous and I induce PVD. Because of the inflammation, if you leave behind some vitreous, you can have some macular membranes and all. But if you look at the video, I'm trying to induce PVD and it's hard. Okay. If it's hard there, it's even harder in the peripheral retina. Okay. And because the retina is 100 times stronger in the posterior pole, just imagine what happens in the periphery when you do some undue traction with the kind of vitrectomy that you do. Next slide, please. So, is it really costly to do a mechanical type of anterior vitrectomy? Yes, perhaps. If the answer is yes, if you're moving from the Wexel type of vitrectomy, please don't do that anymore. Okay. I have asked our residents in TMC to survey all training institutions in NCR and the surrounding areas with regard to availability of Phaco machines. And all actually have, ranging from Alcon's Centurion, Infinity, Constellation, to that of our other friendly pharmaceutical partners. And all have good anterior vitrectomy systems. Small gauge with high cut rate at that. And we have been working with Alcon as to how they can make it easier for our Phaco surgeons to choose and make use of this technology. We have a distinguished speaker on this topic from Alcon, so I will skip that for now for a more detailed discussion later. Next slide, please. I have time and again discussed this pars plana procedure with my anterior segment partners in practice, including even our very own chairman, Vic. Over the years, it has become a requirement for residents in training to do a number of procedures involving the pars plana. They're required to do a number of intravitreal anti-VEGF injections. They are taught how to do pars plana vitreous tap for endophthalmitis using much larger needles. Fluid misdirection syndrome during routine phacoemulsification procedure is managed by doing posterior sclerotomy in the area of the pars plana. The infamous posterior assisted levitation using a spatula via pars plana incision, as described by Charles Kellman, to salvage a sinking nucleus, a procedure I'm personally not in favor of, as it carries tremendous risks of vitreoretinal traction and retinal damage. It's even performed by some of our brave phacosurgeons. Then why not learn and why end teach the posterior approach? Dr. Koh and I have agreed, that the rate limiting step for our phacosurgeon brothers is performing this procedure is the trocar insertion. The fear of generating too much pressure in inserting the trocar and making the vitreous prolapse even worse. The fear of puncturing the eye through and through. Next slide, please. If you will look at how I do it, of course, I've been doing it for the last 15 years, but you can get to this level after just doing it a few times. It's not so hard. This eye had phacoemulsification. Of course, I sutured the wound, but do you see any leak? Nothing. Okay, but you have to learn it, of course. Okay. Now on the other video, how to take it out? Just take it out. Okay. Do I have to suture it? Well, in the beginning, because probably I would insert the wrong way, I did, but no, I don't. I think the last time I sutured was, I cannot even remember. Okay. Now, the picture down there would be probably what will be discussed also by our next speaker. Next slide, please. Well, just to let you know, there's an actual eye model wherein you can learn how to do a limbal vitrectomy as well as pars plana vitrectomy. I think one eye model is about $48 US. Okay, I don't know if Alcon can also help us get one for each of us. I don't think so. Anyway, next slide. We're going into the videos of, this is actually a video of a TMC resident suffering from, who had vitreous loss during surgery. Of course, the sequence will not be as ideal, but she followed, I was telling her what to do. Don't go out, put gel first, just as what Dr. Ko said. Suture the main wound. Okay. She had difficulties inserting the trocar, but not so bad. When you insert the trocar, part of what you should be confident with would be the first hit on the conjunctiva. You should always direct it straight inside and don't go back again because you will cause a lot of conjunctival bleeding. Okay. Part of cataract surgery now is you don't want your conjunctiva to be hyperemic. Okay, so this one had a red eye because she attempted to pierce to puncture the conjunctiva and then backed up. Okay. Anyway, what the video is showing is that after a very good vitrectomy, pars plana, Look at what she's doing now. She's doing INA, and she's not even scared that the posterior capsule will enlarge, and it did not. With the aid of the triamcinolone that Dr. Ko mentioned probably 10 times during his lecture, aided the surgeon to identify, remove much, if not all, continue with the phacoemulsification as if nothing happened, and implant the planned lens. And this is a resident. Okay. Ended up putting it in the bag. I did not edit the video. Okay. Well, that was an edited video part, but everything went well. This patient saw 20/20 the next day. That one, the removal of the throat. There are things you cannot learn through lectures like this. You have to do it. Next slide, please. This, okay, I thank Dr. Asaf. I practically just took this from YouTube. I don't know him. Okay. So anyway, what I'm trying to show here is that sometimes when you're a very good phacosurgeon, you can also be careless. Even this was finished already with these maneuvers. He developed a posterior capsule, but he managed it, I think, without any problems. He put the gel as instructed by Rich, tried to maneuver with, took out the remaining nucleus, put gel to identify if there's any vitreous in the anterior chamber, and proceeded with the pars plana vitrectomy. He even used a big gauge. I couldn't see in the video if he used trocar and all, but that's not the point anymore. The point is, with the pars plana approach, the plan of putting a premium IOL, he still did it. I just want to show you how he placed it without any problems. Look at the tear. It did not move at all. It did not even enlarge at all. That's, there are rings there, so I suppose that's a premium lens, multifocal. Next slide, please. So, these are the basic principles of anterior vitrectomy, most of which Rich already talked about. The do's and don'ts, regardless of approach, but better achieved through pars plana. Always put OVV before withdrawing the phaco tip. Always suture the main incision wound. Always consider triamcinolone to better visualize the vitreous. I have been a vitreoretinal surgeon for the last 24, 25 years. There are days I cannot see the vitreous. Always consider, always visualize the cutter port in the pupil. Don't do vitrectomy without visualizing the tip of the vitrector. Always move the cutter towards the vitreous. It's different from what you're doing. What you do is you engage your phaco tip or INA with the cortex and then pull it centrally. You don't do that with vitrectomy. What you do with vitrectomy is you engage the vitreous and you follow the vitreous towards the periphery. Always use the highest cut rate, low flow vacuum, and low IOP bottle height. Always use cut IA mode when dealing with the vitreous. The cut IA cut, I just hear it from Rich. All I know is the aspiration is always on, and then I hit my foot pedal to turn off or turn on the cutter. I think most, including Alcon, has copied the vitrectomy machine settings with your Centurion. Never let the AC shallow, never use the phaco incision site for vitrectomy, never phaco in the presence of vitreous, never chase the nucleus in the vitreous cavity, never perform a WEX cell vitrectomy, please abandon that, never pull the vitreous anteriorly, and never implant an IOL with vitreous in the anterior chamber. Next slide, please. Almost finished. How do I choose? So I was anticipating you'd ask this, so I might as well talk about it. How do I choose which approach to use, limbal or pars plana? Well, the assumption is there is vitreous in the anterior chamber. That's why you want to do vitrectomy. Use triamcinolone to help visualize the vitreous. Using triamcinolone is always a good idea. The decision as to which approach I use, I usually base on two things: the size of the tear and my actual goal, so to speak. It is hard to say in definite terms exactly what is a small tear and what's a large tear, but based on my experience, a posterior capsule tear that is less than 3 millimeters on its widest diameter is a small manageable tear. So if your tear is less than 3 millimeters and you want to maximize your chance of still implanting that planned lens, especially if it's a multifocal lens, pars plana approach is your better choice with all the advantages we just mentioned. You don't want that tear to get any bigger. If putting in a sulcus fixated 3-piece IOL is already your consideration, then limbal approach would suffice. If the PC tear is equal or greater than 3 millimeters and you want to make sure that you will still get to place a sulcus fixated IOL at the very least, or the planned intraocular lens if we get lucky, the chosen procedure must be PPAV. If you do the limbal anterior vitrectomy, at best, you can still implant a lens in the sulcus. But many times you end up having to defer lens implantation. Next slide. What if there are still nuclear fragments to be removed with much vitreous still in the anterior chamber? Well, before anything else, let me reiterate. Do not phaco the vitreous. The ultrasonic device does not have the capacity to cut the vitreous. Doing so will just suck up all the vitreous together with all that is attached at the other end. Never phaco a nuclear fragment with vitreous around it. It will do the same effect of vitreoretinal traction. Don't chase a sinking cataract. Let it fall. The cataract will not damage the retina. It is your damaged ego that will damage the retina by running after it. Do your proper anterior vitrectomy. Despite this, and proceed with your lens implantation, we will remove your dropped cataract for you. You will still achieve the same final visual outcome. Again, before you proceed with your phaco, vitreous has to be removed. Suggested approach of anterior vitrectomy is determined by the amount of vitreous in the anterior chamber. Again, tremsin alone will help. Minimal means any amount of vitreous above the plane of the posterior capsule that can be easily pushed back into the vitreous cavity with an OVD. No vitrectomy is necessary. Just put enough viscoelastic to push the vitreous below and raise the nucleus anteriorly for phaco. On the other hand, if the vitreous occupies less than a third of the vitreous chamber volume, and again, depending on your goal with regard to what lens to implant, limbal anterior vitrectomy should be enough. If much of the vitreous chamber is with vitreous, pars plana anterior vitrectomy will definitely be of greater advantage. Personally, once there is vitreous in the anterior chamber, pars plana anterior vitrectomy is my preferred approach. Next slide, please. Now, to summarize and emphasize key pointers, again, not all cases of PCR need vitrectomy. Know your limits as an anterior segment surgeon and always consider referring to your retina friend. My personal bias is pars plana anterior vitrectomy is the better approach, but of course, do what you are comfortable with. Pars plana anterior vitrectomy is most advantageous, but the phaco surgeon has to learn the technique. Last slide. Lastly, certainly the goal of this session was not to teach you online on how to do pars plana anterior vitrectomy and assume you can do it overnight if and when the need arises. The intention was, one, to convince you that the phaco surgeons, that there is another approach and that there are cases when the limbal approach will neither be efficient nor sufficient. Two, to convince other training institutions that it's about time we formally incorporate anterior vitrectomy in the residency training program, just as we have started it here in TMC Eye Vision Institute. It has to be formally taught, wet labs included, and not just allow our residents to learn during their private practice, just as how most of us elders have experienced. And three, to my fellow retina colleagues, I'd like to assure you that we will do it right. I know not everyone is convinced. Hopefully, there are some retina colleagues who are here with us tonight, so we can have a healthy exchange of opinion and ideas later in our discussion. But overall, I truly believe it's time. Thank you.
Thank you very much, Dr. Salud. That's a very enlightening lecture, and I'm sure the audience now has a better feel of how PPAV works. Now, before we move on, as promised, we will be conducting a poll to get an idea of what you, our viewers, think, having heard about PPAV from our previous two speakers.
So if everyone could kindly take out their smartphones and just scan the QR code flashed on the screen now, you will be directed to our short poll. And feel free to send us the poll answers now, up until later, and in a short while, we will be looking at these results. So please answer the 7 poll questions as it appears on your smartphone screens. Again, if everyone could take their smartphones out, scan the QR code on the screen, you will be directed to the short poll. So please send us the answers, and later we will be looking at these results.
Now, Rob, I'm sure these two lectures have generated a lot of interest and as well as more questions from our viewers. But before we get into their minds, let me first ask you, being a VR surgeon yourself, what do you think about this procedure, especially in the context of it being taught to everyone, including people like me, who we're not really used to doing pars plana surgery? Rob?
Well, as a VR surgeon, we're used to inserting the trocars. I think it is one of the steps that may involve a slight learning curve for cataract surgeons if they choose to adapt this technique. But definitely, it's a procedure that's worth learning, as it will not only help you optimize your surgical results, but it can also lessen the risk for retinal detachments or other retina complications for your patients in future.
Thanks, Rob. So now I think it's time to see what the viewers think. So I think we're ready to look at the comments section and see what questions we can answer.
Okay, for our first question, I think this is for Rich. Can you please clarify how triamcinolone bonds with the vitreous?
Hi, Rob. I cannot. I was hoping you would answer that for me. I know it does. I don't care how it does it. It just does.
Arnold, do you have
maybe Arnold
an answer?
But again,
can you clarify how triamcinolone bonds to the vitreous?
I know I should know this, but practically all I know is some of the particles would bond with how they happen. I don't know. What I know is that you don't have to inject much. Okay. If you inject much, you will sacrifice your view. You just have to inject a little and let some of the what do you call that, the solute, okay, to attach with the fibers of your collagen, I think.
Do you use the solute only? Do you let the triamcinolone stand and just get the solute, or it's okay to mix it and take that in and inject?
It comes in a small bottle. I think Alcon also has it as Tri-Essence. Okay, so you just mix it, get a little. Okay, when you inject it in the anterior chamber, just enough to stain, or if you feel like you've placed too much, you can wash it off, and then whatever remains there will actually be the one staining your vitreous.
I've seen some people mix it in half, 50-50 with the BSS.
Yeah.
Pero put it pure, no need to.
When they mix it, I think their intention is there are still surgeons who don't want to use it because they're scared they might leave behind and cause increase in the pressure of the eye. Yeah, but again, if you do the right technique of vitrectomy, all those will come out with you. I mean, with the vitreous.
Okay, now I think we have more questions, so let's move on to the next one. So this is for Rich. Nice lecture, Dr. Ko. Simple and clear. Basic question. May I ask, where can we buy triamcinolone? Since we're all into triamcinolone now.
Oh yeah, should have bought stocks in triamcinolone.
Maybe.
As mentioned by Dr. Alcon has that Tri-Essence. But actually, locally, yung Kinocort or Kinolog, you can, from Daswani actually, we use the one supplied by Dr. Daswani. It's very cheap. So again, you don't have to mix it. It's readily available. Kinocort or Kinolog. Mercury or Daswani.
Okay.
More questions here. Okay. What would be the minimum equipment or instrument recommendation to be able to do pars plana anterior vitrectomy, especially in a non-center or provincial practice? I guess this is for Arnold.
To be able to well, again, as what I said a while back, if you're doing Phaco and you're using a Phaco machine that is updated, I suppose, that comes with the vitrectomy capability. So all you need is the vitrectomy probe that is also sold by the company that produced your Phaco machine. So that's why I was telling a while back, there's actually not much increase in your cost because everything's there already.
Okay, I think we can move on to the next question if we have more. Okay,
If one last
go ahead,
thought.
Arnold.
If
Please
if,
go ahead.
if a doctor our age is asking, because many years ago, what Phaco machine you were using, when you encounter a vit loss, you need another machine that will help you
Yes.
out.
That's right.
Now everything comes in the same machine, so it's not going to be difficult.
But just to follow up on that, Arnold, does the machine need to have posterior pars plana vitreous capabilities or not?
No,
no, right?
no. The clearest example would be Centurion.
Centurion.
Centurion has an anterior vitrectomy capability. And what is so good about it is that the anterior vitrectomy cutting rate before would be maybe over 10 years ago, was I think maximum of 600 cuts per minute. And now it's up to 5,000. So just imagine how safe it can be for your vitreous. I don't know if you fully comprehend the relationship between high cut rate and safety for traction. The higher the cut rate, the safer for your vitreous.
Okay, so I think we're ready to move on to another question. Okay, so on the screen, I guess Arnold or even Rich can answer. Where do you put your trocar? Will it depend on the location of the rent? Go ahead.
No, I'll answer Rich. Most Phaco surgeons would do your Phaco temporarily, right? Okay. So you will put your trocar a little off, not in the same line as your Phaco incision, but not too high or not too low, because the ridge of your orbit will limit the movement of your cutter as you maneuver towards the anterior chamber. So you want to do it here, okay, at the canthal area, but a little off your Phaco incision, regardless of where your rent is, okay, because that cutter will just, that's why I was saying it's a safe procedure unless you don't follow the principles. And one of the principles is that you just stay under the posterior capsule rupture, which is in the same line with your pupil. So just stay there. You don't have to move. Just stay there and cut. Okay. Whereas compared to your limbal vitrectomy, you move around. Okay. That's why you cause a lot of problems. Here, you just stay under, regardless of rent location.
Arnold, can I just ask, that case you presented with a TMC resident, was that done under local? Did the patient have to undergo a block? What were the circumstances?
That was under topical anesthesia. We didn't even have to add. We just added topical.
For the trocars? Okay.
Yes.
Okay.
Well, I cannot remember if she placed subconj a little lidocaine subconjunctiva, Lee. Okay, but in the cases that I've done, I don't even do that.
And that was gauge 27 or 25?
25.
25.
Okay, Rob, why don't you check? I think there are more questions.
Okay. When do you abandon putting an IOL when you have retained lens material in the vitreous and will refer later to a VR surgeon? Maybe Rich? Who wants to answer this? Sige, from Rich's point of view first.
So when do you abandon putting an IOL when you have retained lens material in the vitreous and will cover?
Yeah. So
It depends on how big it is. My point is what I was mentioning earlier is that if the vitrectomy is too toxic and you've prolonged it, do not force yourself to be able to put in a lens secondarily, because so that's what we always think, we have to put in a lens no matter what happens, and that's not true. You can always tell the patient it was just something bad happened, we will reschedule you in 3 or 4 weeks and put in a better lens. um so basically I think that's it.
Arnold,
Me.
and your thoughts? Yeah, please.
For as long as you can put an IOL that is stable, do so. Okay. Then we can take out whatever fell onto the retina. The only times before that I've mentioned Rich, wherein I said, oh, this guy even put an IOL. I think I mentioned it twice, and those 2 times were occasions when even the Phaco fragmatome could not eat the nucleus that fell under. Okay. The cataract was so hard,
Dense.
was
A
so
lot.
dense that even the fragmatome could not handle it. So how will I take it out? So I had to push aside the IOL and lift the lens anteriorly, something that would have been a lot easier for me if there wasn't an IOL there. Okay. So I guess the answer is, as a phacosurgeon, if you think the cataract is too hard that even a retina surgeon will find it difficult, don't put a lens. But if it's an ordinary cataract that just so happened to fall, we can handle that. Put the lens that you want.
And I guess please keep the cornea clear.
I agree.
Unfortunately, we don't have a lot of time anymore. So thank you for your questions. We will try to address the other questions before we wrap up the program later. So please just type them in. And again, please scan the QR code to access the poll.
Okay, so many good points have been discussed from the first 2 lectures. And I think during the Q&A, we touched on this also. Our Phaco machines do have capabilities that most of us aren't really aware of or haven't made the most out of yet. And one of these machines is the Centurion by Alcon.
So now to take us through the capabilities of this machine, let us give the floor to Mr. Mahesh Mangali. Mahesh has been an Alcon associate for the last decade with experience in professional training for corporate eye care companies. And currently he is the regional training manager for Alcon sales and marketing for the Asia Pacific region. So let us listen to Mr. Mangali.
Thank you, Dr. Rob, and for the introduction. And also, I'd like to thank Dr. Richard and Dr. Arnold. There were many practical polls and experience learnings what you have put in these slides, which made my talk easy to go through. And also thank all the members for providing us this platform to talk on Alcon platform. So today's topic is to maximize your anti-vitrectomy experience with current Phaco equipment. So I hear from Dr. Richard and Dr. Arnold many times remove all the vitreous from AC and minimize or preserve the size of the PCR and minimize the mechanical trauma to the iris and also equalize the AC and PC pressure. So I feel this is a good introduction to my topic now. And you need to really have a robust machine to provide all these capabilities. With this introduction, I'd like to introduce my Phaco equipment to understand more on different capabilities and modes. Next. Yeah, with the Centurion vision system, we have introduced the advanced technology, which is similar to Constellation because Dr. Arnold is already spoken about it. This technology is called as UltraVit, and it is 23 gauge probe. Both irrigation cannula as well as the cutter are 23 gauge, which provides the efficiency in removing the vitreous from smaller incision size of 1 millimeters. And this technology is a dual pneumatic, single-use tips with a capability of 4,000 cuts per minute. And with new software, it is also capable of 5,000, as we have discussed. And this approach is bimanual procedure, and the surgeon can go either approach what he desired. Next. So as we have discussed in the previous two lectures, and I strongly feel the anti-vitrectomy of Centurion vision system acts like a multifunction tool to remove the prolapsed vitreous efficiently from the anterior chamber, and also remove the non-vitreous materials like nuclear fragments, epinucleus, cortex removal, as well as the OVD after IOL implantation. Additionally, it will provide you the option of performing surgical peripheral iridectomy in glaucoma cases. So with the various capabilities, we need to really see what kind of modes are available with our machine. We have introduced 6 different modes with Centurion vision system, right from anterior vitrectomy, epinucleus removal, IA cut, peripheral iridectomy, viscoelastic aspiration, and recent iteration is cut IA. As the name suggests, the function is very well appreciated by all the surgeons, those who experience with Centurion vision system. Next. So the first mode is anterior vitrectomy. As the name suggests, we use it for removing the vitreous, and the function is both cutting as well as aspiration is provided in single foot pedal position. By this, you have efficient removal of the prolapsed vitreous, and you can adjust the parameters as required. So the more important is to maintain the AC and PC pressure. So we need to lower the bottle height to almost like 40 to 50. Next. So when to use the anti-vitrectomy mode for removing the prolapsed vitreous, and what benefit I'm going to get with this mode. Because of high cut rate of 4,000 to 5,000 possible with this mode, you are going to reduce the traction on vitreous, and it increases the efficiency and shortens your procedure time with this cutter. Next. The second mode is epinucleus removal mode. As the name suggests, it is used to remove the epinucleus in the presence of prolapsed vitreous in the anterior chamber. And this pretty well acts like a 3D system of constellation machine, where the cut rate decreases as vacuum increases with foot pedal depression. And this mode helpful to remove the epinucleus in presence of vitreous. Next. So to use this mode is suggestible to remove the epinucleus. And as you see the picture, the cut rate starts from 1500 and reduces to 500. So from the surgeon's point of view, when you want to remove the epinucleus, you need to first cut the vitreous and then remove epinucleus. Hence, we use the higher cut. We start with highest cut rate, and then slowly we lower the cut rate to remove the epinucleus. And the benefit is you can maximize your cut rates as well as OVD with this mode, and there will be no chance of trauma to the iris or capsule because you are cutting and removing both in this mode. Next. The third mode is IA cut. As we have seen, Dr. Richard was talking about cut IA and IA cut mode. Once you remove all the vitreous, then you need to go to the IA cut mode to remove all the non-vitreous materials like maybe epinucleus, maybe the cortical matter, or maybe the partial nucleus material. Here you can use the foot pedal 3 as a cutting if it required. If not, foot pedal 2 with aspiration, you can remove the most of the material. Next. So any vitreous materials which is already removed with cut IA, then you will be going with IA cut to remove the residual nuclear fragments or cortex. And with this mode, the benefit is it is because you are using the mouth of the vitreous vitrectomy cutter, it is easy to hold and cut the materials without further collapsing the vitreous into the antechamber. Unlike if you go with IA coaxial or bimanual, you don't have the cutting action. So you may approach or occlude the vitreous, and you may need to exchange the instruments again and again. With this mode, you don't need to exchange the instruments, because whenever is required, you can go to foot pedal 3 to cut. If not, you can aspirate all the materials. So hence it increases the efficiency to remove the residual material after completing the vitreous removal, and reduces the procedure time. Next. The fourth mode is peripheral iridectomy. As the name suggests, this mode is used to remove the part of the iris tissue by cutting with the help of the vitreous probe. And with the new software, we have the capability of steps starting from 1 cuts per minute, 5 cuts per minute, 10 cuts per minute, like on. And the beauty of this step is the cutter is only activated at the end of the foot pedal, as the diagram you can see here. End part of the foot pedal 2, you can see the cutting action here. So this helps you to have a very good occlusion and then cut the iris. Next. To perform peripheral iridectomy, it is recommended to place the open port of the probe facing the iris to have a good aspiration and occlusion. Once you hear the occlusion sound, further you depress the foot pedal to activate the cutter. And the different cuts per minute is used for various thickness of the iris, like thin iris or thick iris, where you can require the cut rates as desired. And the benefit is less trauma to the eye and faster recovery. You can very well perform the peripheral iridectomy on the iris tissue with a very good size, desired size, and no main incision required. And all this procedure can be performed through 1 millimeter size, which enhances the recovery time as well as shortens your procedure time. Next. The fifth mode is viscoelastic aspiration mode, and this is exclusively used to remove the OBD in the situation of vitreous prolapse. And here you will be using the highest cut rate, because you are going to remove OBD as well as vitreous, which is entangled in the antechamber. Next slide, please. So this step is used to remove the OBD and vitreous prolapsed after the IOL is implanted with the efficiency. And if you, in case you go with a bimanual IA or coaxial IA to remove the OBD, you may have the left out vitreous strands prolapsing again. So, and occlude your aspiration port, and you need that time you need to come back and go with your cutter again. So this step will definitely help you to avoid this exchange of instruments, because whenever you require the cutting action, it is already available there with this step. And by this, including the action of cutting as well as aspiration, you can efficiently remove all the left out vitreous strands as well as the OBD and any materials available in the antechamber. And also you can use higher flow rates without further collapsing the vitreous into the AC. Next. The last step is cut IA, as all the machines have this, and every surgeon is very well known with this mode. And we have introduced this on demand from the surgeons to have the same feel with their previous machines and adopt to the same practice of removing the vitreous. So the difference between anterior vitrectomy step and cut IA step is, in anterior vitrectomy you have two foot pedal positions where cutting and aspiration is done in the same position of foot pedal, whereas in cut IA you'll first cut and then aspirate accordingly. So with Kataya mode, your procedure time is a little bit more compared to your anterior vitrectomy. Next. So with this mode, you can use to remove the vitreous, prolapse vitreous by using the highest cut rate possible with the optimal flow rates. And because you are using the high cut rates, you are going to reduce the traction on the retina and minimize the trauma to the iris. And it also helps us to preserve the size of the posterior capsule tear. Next. So in addition to all these 6 modes, there are 2 functionalities which I would like to highlight in this platform. And I'm sure most of you know, and if not, then this will be a good revisiting to the functions of anti-vitrectomy. First function is bit cutter button dual assignment. Once you set into the foot pedal settings, like whether you want cutter on or off, it is similar to what Richard was telling. You can just aspirate with the help of cutter on and off. So this function will help you to enable the cut and disable the cut and utilize the whole cutter as an aspiration probe according to the situation what you desire. Next. So performing the anti-vitrectomy in pediatric cataracts or kind of removing the pediatric cataracts, you require very good probe to aspirate all the materials. We feel this mode can help to remove the vitreous as well as the soft part of the nucleus, and you can adjust the cutter on and off without manually adjusting and depending on the assistants. Next. So the other important functionality I like to quote with the learnings what we had today from Dr. Richard as well as Dr. Arnold is to preserve the uh, pressure between the AC and PC. So usually for the Phaco steps we use higher bottle heights around 60 target IUP, or rather I put it as 80 to 100 bottle height with the gravity machines. But when you come in the situation of the PCR, you are going to reduce the bottle height to 50%. That means almost like 50, right? So in this situation, once you complete the vitrectomy with the ultraviolet probe, in case a surgeon required to go back to Phaco step or the cortex step, he has to maintain the same bottle height to minimize the tear size and equalize the pressure in AC and PC. For that function, this width irrigation maintenance option is given in Centurion vision system. By selecting S to this, it will override the higher bottle height what you were using in Phaco step 2, the same bottle height what was provided in by performing the vitrectomy steps. Next. So this option is very useful and this will maintain the chamber pressure between AC and PC and help us to minimize or preserve the tear of the PCR. And you don't need to manually adjust or lowering or increasing the bottle height when you do transition from vitrectomy steps to non-vitrectomy steps. Next. In summary, this ultraviolet 23 gauge vitrectomy probe is a single-use device to remove the vitreous as well as the other materials from the antechamber during the surgery. And it works with a dual pneumatic drive system, which is similar to our Constellation vision system. And this Centurion capability provides the surgeons for managing the cut rate and vacuum as required by the situation as a multifunctional tool. And in addition, it provides 6 anti-vitrectomy modes. I feel with these robust capabilities of our machine and the learnings what we had from Dr. Richard and Dr. Arnold on principles of performing vitrectomy, I'm sure this is the best device for anti-segment surgeons to manage the vitrectomy and increase the success rate of PCR managements. And this will help you to boost the confidence in terms of even the surgeons who are going to learn and transition to learn the vitrectomy. With these capabilities, it will help to learn faster and adapt to these best principles of vitrectomy. And additionally, you can contact our Alcon representative for additional information, or you can mail to us in case you have any queries. And thank you for all the doctors and the listeners.
Okay, thank you very much, Mahesh, for walking us through all the capabilities of Alcon's Centurion machine and for the very informative lecture. It's a great supplement for our first 2 presentations. Now, for you, our viewers out there, if you haven't done so yet, please continue to type in your questions because I think at this point we are ready to call in everyone. All our guest speakers, please let's bring everyone in. Dr. Ko, Dr. Salud, and Mr. Mahesh Mangali for the Q&A.
So we hope you were able to answer our poll. I think we have about 100 responses. So thank you for all of you who responded and answered that poll. We have those results now, and Dr. Salud will briefly summarize and discuss the results of this poll.
Abby, okay, I'm seeing the first one. The number one. I'm just seeing number one. It's basically, let me just take this out. 64% are doing the usual bimanual limbal approach. Surprisingly, there are still those using a coaxial single port and a Wexel. Okay. Both of which should be, I should stay stopped.
Archived.
Yes. You know the Wexel, I don't know if you know the principle of Wexel. When you put it beside the vitreous, it dehydrates the vitreous by sucking out the water. So the Wexel expands. When it expands, even without pulling it, you're pulling the vitreous. Okay, so you're actually doing damage even if you think you're not. Okay, so don't use the Wexel. The coaxial, you're using one port. So you're practically, that's the procedure that will mostly hydrate your vitreous. And it's the hydration of the vitreous that actually makes it come out even more. So the two things that you just have to do would be the bimanual limbal approach. I'm not saying it's not a good procedure. It's still very good. All I'm saying is it cannot handle all. That's why you need to know the other approach, which is pars plana. Next would be there. Well, most
24
a lot
better.
yes, 20 or 40 better. No, greater. Greater ba yan? Greater. Worse than 2040. So majority will be between 2025 to 2040. Well, I cannot comment on that. But I guess my point again is if you end up with a 2030, 2040, and you operated on an eye that was 2020 to 2025, cloudy, so the complaint was the cloudiness, and then they end up with a 2040, that's not acceptable to my mind. To my mind, because that's what I hear from my Phaco partners. And I think the goal of every Phaco surgeon should be the same. Are you confident? Sort of. Yes. Wait. It went back. So number 3, sort of. Yes. No. Sort of. Sort of is 50%. So I don't think you are confident. That brings me back to my point. How can you be confident when I graduated more than 20 years ago and I learned my vitrectomy, anterior vitrectomy during practice? I have not talked to anybody except for the younger ones, probably in the last few years, who have been confident from graduation. Okay, so that brings me back to my point. I think we have to teach it. What if you're a very good phaco surgeon and you finished your residency without a vit loss? Then I pity you when you develop one during your practice. Okay, next question. I believe you should learn. Very good. I agree with you. You know, I purely practice retina. So if there's somebody who should contradict this, I think it should be me. Okay. But I'm totally for it because I believe that this is how you should treat the vitreous. Next slide. Next question. enough to allow safe. Okay. Okay. As a retina surgeon, I would rather that you think of the number 2, the retinal complication, as your primary concern. Okay. For me. Okay. Once you develop a vit loss, okay, which was not part of your plan and with your talk with your patient, I think your primary concern should be that. Be able to handle it without complications. And as a side effect, you can continue, as a side effect of what you're going to do, you will be able to pursue your plan. Now, one last here, we're all mature people here. What I wrote down here is that will the insurance cover for the extra expense? And we know very much in the Philippines, in the States, that's what the surgeons will ask. In the Philippines, what will be asked is who will cover for the extra expense? Is it going to be me as the surgeon? Or if it's going to be the patient, how will I tell the patient? So honestly, I think the answer here is it's not fully correct. Okay, because in my own conversation with phaco surgeons developing or having vit loss, the expense is their primary concern. One of the. Next slide. Next question. Very good. I think you should be interested.
Yes.
Okay. Next slide. Question, sorry. Oh, thank you. There's only 1%. I don't know who that 1% or 1% is.
I may have an idea who it is, but
okay. Then that
let's
means you
leave
want
it for
to be
another.
You want to be stagnant. Okay, you want to be doing what you were doing 20 years ago, 40 years ago, 30 years ago. And I'm proud that our chairman here in Medical City is in agreement with what we're thinking, together with the head of our cataract service. Okay, thank you.
Okay, thank you, Arnold.
Thanks, Arnold.
So now
Thank
we
you
can
too.
move on to answer a few more questions from the audience. So this is from our past president of the Vitreoretinal Society of the Philippines. So Sherman, thank you for phoning in your question to me. So I may be wrong, but I haven't seen Centurion or Infinity anterior vit packs supplied with trocars. Does it come with trocars now? And does it come with 25 gauge or 27 gauge? If not, does the cutter of the Constellation fit in the Centurion machine? I guess this is for Mahesh.
Maybe I should answer that first.
Go ahead, Arnold.
Okay, go ahead.
Then we'll let
Mahesh,
later on. First,
yeah.
the pack comes with 23 gauge. Okay, and it doesn't come with any trocar. Okay, so when we started doing this, we would use either gauge 23 or the gauge 23 of Centurion, and I would get a trocar from the packs that I've used for Constellation. Not a good idea because you're reusing a trocar. That's why I've been in communication with Alcon, and they are trying their best, and I think I'm starting to hear good feedback that they will supply it. Because if you go abroad, if you go outside the Philippines, the Constellation pack. Constellation is the pack that we use for our vitrectomy. You can buy them tingi. Okay. Here, it's available as one whole pack. Okay. They have their own reasons, probably related to how Filipinos would reuse things. Okay. So they don't want to do that. But because of what we're discussing now, they're working on it. Okay. Now, Alcon, my apologies, but I have to talk about other machines. We're talking about anterior vitrectomy. Other other machines like Visalis. Okay. They have their vit packs. Okay. You can buy their trocars separately. Okay. even that of Earthly and the other platforms, you can do that. Now, as to whether the gauge 27 and gauge 25 can fit into the Centurion, no, it cannot. Okay, I've tried it. In fact, I've tried to cut and all and put them together. It can work. I think it can work. I've tried it, but I don't think Alcon will agree to that. Okay. Even Michael Cardamone, I had to discuss with him and he told me, Arnold, please don't do that. Okay. But to my mind, it can be done. But then again, if your hospital is using a Constellation a machine for your vitrectomy as well as for your phaco, then you have all the advantages. You can use your gauge 27 in your 25, but lastly, 27, I don't think 27 will do good for anterior vitrectomy because your vitrectomy probe, you want to bend, you want to maneuver it so you can go into the anterior chamber. With the gauge 27, it bends. So you're good with 25 and 23.
Can we hear from Mahesh?
Yes, I very well align with Dr. Arnold. These cannot be interchanged. And if you really look at the anatomy of the probe, there is a difference between the Centurion anti-Vitreoretinal probe and Constellation probe. Constellation probe is designed exclusively to fit into the posterior segment anatomy so that you can reach closer to retina, whereas anti-segment is for the anti-segment anatomy. So the Alcon representative can demonstrate the differences physically, but we cannot interchange both. Thank you.
Okay. So I think we're ready for the next question. I think Mahesh, you need to take a crack at this as well. So is Alcon planning to come up with a small gauge vitrector? And if yes, shouldn't you, meaning Alcon, consider packaging triamcinolone with the vitrectomy cutters?
Sabihin mag-work. It's working.
I rather take it as a suggestion for our development rather than a question.
Of course. Understand perfectly.
Yeah. It's a kind of a suggestion for us to make the mice. But as we don't have, like for anti-segment, we have 23, but posterior segment, we have reached almost like 27 gauge. And we are separating the triamcinolone. So maybe the local representative can contact to you and help you out on this.
Okay. Thank you, Mahesh. Do we have time for another question or?
Yes.
Very interesting questions we have. Okay. What technique is better during vitrectomy? Placing the infusion in the anterior chamber or making another pars plana port for infusion?
That's, sorry.
Arnold, I was going to say, kinakatakutan nga natin yung pagtusok. Ayan, dalawang tusok pa.
No. Don't do that. Just one. Okay. But can I answer? Can I make my own comments? Okay. The limbal approach is still a very good approach. The problem with limbal approach is you're putting in your infusion and your cutter on the same anterior chamber. So you're generating pressure in the anterior chamber. You're putting fluid, and the tendency is for that fluid to go behind the vitreous. That's why I was saying you're going to hydrate it. So a good maneuver is you put your irrigation in and out of the eye. Okay. So there will be occasions wherein you're doing dry vitrectomy, no infusion. Okay. You don't want too much fluid going behind the vitreous. So that's one maneuver. Something you don't have to do when you're doing a posterior or pars plana approach. And last, again, when you're, as I mentioned a while back, putting it pars planally, so the cutter is like parallel to your iris and perpendicular to your pupil. Okay, so the port is right directed towards the vitreous that has gone into the anterior chamber. Now, when I tell Rich that when he's doing the limbal approach to put the cutter way below the posterior capsule, that's a good maneuver. But there's no way you can put it like this. So it's going to be tilted. And there's still going to be some traction going into the periphery. Okay. And for you to be able to do it like this, you're going to distort your cornea. So there's a limit to what limbal approach can do. That's it.
Okay. Thanks, Arnold. I think we have time for one more. So how do you insert the trocar? This is very practical. How do you insert the trocar in a very soft eye? Do you have any tips? I guess I'll direct it to either Arnold or Rich. You can take it.
I've been telling the residents. First, you have to suture the wound. I mean the phaco wound. Second, how to insert it. When we do vitrectomy, the reason why we angle it, because we want a self-sealing after a long vitrectomy. Okay. Now, when you're going to do anterior vitrectomy, it's going to be a very short procedure. So I don't think you have to do that maneuver. If you can do it, well and good. But if you can, you just have to go straight and aim towards the direction of the optic nerve. Okay. So you imagine, don't hit the optic nerve. You look, the direction is towards the optic nerve. And then, again, it has to be at best at the canthal area, but because your wound is in the same line, make it a little off, but not too high or not too low. Did I miss? I don't know if I answered the question, right?
No, just to clarify for them, those who asked the question, you notice my videos on the anterior vitrectomy, the corneal approach. I never sutured the main port. So I guess, Arnold, you're saying if it's pars plana, they have to suture the main phaco port before they make the puncture.
Oh, yes, because you will generate high pressure. Okay. But the trick is, again, when you insert, don't dilly-dally. Okay. You have to be determined about what you're doing. Once you hit your conjunctiva, you have to go straight. If you do like this, you're pressing onto the eyeball, your wound will open, your phaco wound, and it will leak. If you go back to the video, you don't have to do that, but look at how I did it. The eye practically doesn't move. And everything goes in smoothly. Well, it cannot be taught over internet. It cannot even be taught over conversation. It has to be some form of a wet lab. And I think our head of cataract service and Alcon are doing it already. So as we can have a wet lab for this on a regular basis.
I think it's sort of similar to for those doing injections already. You have to be confident in doing your injections, because I've seen initial injections where they will hesitate going in and you result in subconjunctival hemorrhage. So, sige. So moving on, the next question is for Mahesh. Does the Infinity also have the features you mentioned in the Centurion? Which features will the Infinity not have?
Okay. Thank you for asking this. With Infinity, we have only two modes, cut IA and IA cut. And all other four modes, epinucleus removal mode, viscoelastic, peripheral iridectomy, and anti-vitrectomy mode are not available with Infinity. That's the technology advancements which we have introduced with Centurion.
So that means you need to upgrade your machine. Okay. Thank you.
Mahesh, can I ask Mahesh?
Yes, Dr. Arnold.
Mahesh, what's the capability of Infinity? Is it up to 800 only, or can it also go up a little higher?
With the single pneumatic drive cutter, which is old Accurate style, it is 800. But with the new 3 gauge, we have 500 with Infinity.
Okay.
So the difference is with Infinity, we have ultraviolet cutter with the 23 gauge ultraviolet cutter, which can give you 2,500 cuts per minute. And the irrigation is 21 gauge with Infinity.
Infinity is still good.
Yeah. So with Centurion, both irrigation cannula and cutter is 23 gauge size.
All right. Okay.
Okay. We have one more. Okay, interesting. Can I still attempt to do PPAV even if there are no available trocars? I guess what options do we have for entering the pars plane?
Yeah, you can. You can. Well, the difference now is you have to open up your conjunctiva, and you have to have some MVR blade or make use of a new needle that's a little bigger than the gauge that you will use. So you go back to before, but this time your cutter has a better capability.
Older style,
But
and then
yes,
but it will probably take longer also because you have to dissect, and
yun lang.
that's why we
Yun
want
lang.
this. It's so easy to do without any dissection,
Yeah.
transconjunctiva.
Yeah.
But I think it's still possible.
But at least there are options. Yeah.
Old way.
We will work it out with Alcon.
Okay. Thank you very much, everyone. Unfortunately, we don't have time to address all your questions, but thank you to all those who've sent in their questions to us. For the questions that we were not able to address during this time, we will be sending your queries to the lecturers, and we will try our best to send back a reply. So thank you to our guests today and to our partner, Alcon, for this learning opportunity. Thank you also to everyone for tuning in and for your continuous support. A special thank you to Dr. Adele Samson. Is he here? Hi, Adele. Thank you for composing the TMC EyeTV jingle. So that's the jingle you hear at the very start of the program.
Okay, so for the next episode of EyeTV, we have partnered with Oculus. And now, true to the spirit of EyeTV's learning and educational platform, this episode will offer you, our viewers, an online instructional course on corneal diagnostics and imaging. So it should be exciting, at least for me and for all of you, I hope. So with that, it's been a pleasure, and we hope to see you all again in 2 weeks' time via YouTube Live. That's July 9th, also a Thursday, 5:00 p.m. Philippine time.
Please don't forget to fill out the attendance and evaluation form. This is for your CPD units, linked in the comment section. To close today's program, let's hear from one of the top officials of Alcon, Ki-Wan Yoon, who will give us a few words as a testament to our continuing partnership in providing the best ophthalmic care for our patients.
Hello, dear doctors. I'm Ki-Wan Yoon, who is responsible for country franchise head for the Philippines and Thailand. We are very pleased and proud to be part of this episode of the TMC EyeTV for managing the PCR and the Vitreous roles during the cataract surgery. I'd like to personally congratulate Dr. Sidney Chang for bringing this such a burning topic for discussion to your fellow cataract surgeons, which usually not everyone would be comfortable to talk about. And also congratulations to the wonderful speakers, Dr. Richard Goh and Dr. Arnold Salud, for very enlightening and then engaging the presentation. The tips shared by both the speakers are very practical and can be adopted easily with advancement in the technology available now. I'm very happy that Mahesh was given a chance to share about the anterior vitrectomy technology offered by Centurion Phaco system. I'm very sure his presentation will help our dear surgeon listening to this episode out there to maximize the anterior vitrectomy functionality offered by Centurion. I also want to commend the hard work done by the residents of the TMC for making event flourish despite of many limitations we are facing at this time. And also in the last, I would like to echo again Alcon's commitment to continuously support HP education. As Dr. Sidney Chang rightly mentioned in the beginning, while each one us, as the adopting to this new normal, we are committed to bring more and more such an exciting educational event for you. Alcon's commitment to continue education can be experienced through the Alcon Experiencing Academy as well, with the great educational contents available. Thank you so much.
Okay, so we've come to the end of this episode of EyeTV. So thank you once again to Alcon for sponsoring this episode. And of course, thank you to our speakers, Dr. Ko, Dr. Salud, and Mr. Mahesh, and as well as to all of you, our attendees, for joining us and sticking it out with us despite going over time a little bit. So once again, I hope to see you soon I am Dr. Reyes.
And I'm Dr. Rob Papa. Good night. And we will see you in the next episode of TMC EyeTV, Ophthalmic Instruction Without Borders. Have a safe night, everyone. Good night.
Thank you. Bye.
Bye.
Thank you, guys. Thanks, Kevin.
Thank you.
Thank you, everyone. Thank you. Thank you.
Thank you.
Do we leave now?
Thank you, Mahesh.
Thanks, Mahesh.
Nice talk. I'm gonna borrow your slides.
Please.
Dry eye syndrome occurs when the tear film is compromised, causing insufficient tear production or accelerated evaporation. This can result from either an unstable tear film or inadequate quantity of the tear film, both of which may lead to alterations in the ocular surface and result in dry eye symptoms. Hyaluronate is a naturally occurring molecule and major functional component that has an important role in joint lubrication. It is widely distributed throughout the body, including the skin, cartilage, and vitreous humor of the eye. Hyaluronate has been extensively researched due to its strong water retention and viscoelastic properties. This increases corneal wettability and reduces friction during blinking. Hyaluronate can also attach to the cells in the epithelium and form a protective coat, like a matrix structure, which entraps water to provide increased hydration and lubrication to the ocular surface. To enable dry eye patients to better experience the benefits of hyaluronate, Alcon has developed Systane Hydration Lubricant Eye Drops, an intelligent delivery system which combines HP guaiacol and hyaluronate. Upon installation of this intelligent delivery system, the solution becomes elastic and spreads easily over the surface of the cornea. Between blinks, the molecules of the combination of HP guaiacol and sodium hyaluronate adhere to the mucin layer of the tear film. Here they act as a bandage to provide increased hydration and maximize the residence time of the solution on the ocular surface compared to products containing HA alone. In vitro studies have shown that Systane Hydration Lubricant Eye Drops, an intelligent delivery system which combines hyaluronate with HP guaiacol, creates a moisture layer that attaches to the cells in the epithelium, entrapping water and promoting greater hydration, lubrication, and protection than hyaluronate alone. Hence, this allows corneal reepithelialization and restoration of the damaged surfaces of the ocular surface in patients with dry eye syndrome.